Okay, so hi everyone. My name is Onyinyechi Ake. I'm the Director of Global Ultrasound in the Department of Emergency Medicine at Massachusetts General Hospital. And today the title of my talk is Tele-ultrasound, Where Are We Now? So I have no financial disclosures, but I did just get a grant to study tele-ultrasound implementation in the MGH-ED. This was a faculty development award. I have no financial incentives from any of the companies or the products that I will be discussing briefly. So this is the outline of the talk. So first of all, we'll go through an overview of what tele-ultrasound is and why there is a need for it. We'll also discuss tele-ultrasound research, then the challenges, and also the future considerations. So diagnostic imaging is a necessary procedure that is needed for at least 25% of the world population, but it is lacking in vast areas of the world, particularly in developing countries. This was a statement had by the WHO in 2009. And so we see here that there is a gap in healthcare delivery as a result of lack of diagnostic imaging tools and resources. So when we talk about diagnostic imaging, I think a lot of us here are probably familiar with all of these modalities, but let's look at their attributes. So I think X-ray, now we can have a portable X-ray by the bedside. But it has ionizing radiation, so it is not as safe. You can't really change the patient's position during the exam. It is relatively inexpensive and the image quality is okay. What about a CT scan? A CT scan is not portable. It does have ionizing radiation. It's not dynamic. It is definitely not expensive, and I'm so sorry. It's definitely not inexpensive, and the quality is better than X-ray. MRI, we all know it has no ionizing radiation, but it is definitely very expensive, and the quality is also good. What about ultrasound? Ultrasound is portable. It is safe. It's dynamic and it's inexpensive. And I put a question mark here for image quality, because I think that's when most people have more questions. And there's always this discussion of if the quality is user dependent. And we are going to come back to this, so just stay tuned. So point of care ultrasound has a problem. And the problem is that there's not a lot of us out there, so that's experienced doctors or technicians who are doing this point of care ultrasound. And because of that, there is a gap in quality. So when you have this gap in quality, it leads to inappropriate scanning protocols, improper technique, inadequate image collection, incomplete examinations. And I think the worst of it all is for us to have a false diagnosis or misdiagnosis. So how do we solve the problem? Tele-ultrasound. And that's why we are here today, and that's why I'm having this talk. So what is it? Tele-ultrasound combines the use of ultrasound with telemedicine, which allows for offsite or remote expert guidance and interpretation. So when we put tele-ultrasound into the equation, it's able to eliminate this lack of experienced doctors and gaps in quality, because now you have an expert that is able to remotely guide users. This will lead to more POCUS users. And because you have that expert guidance, the protocols will be appropriate, your image quality will be adequate, and that will also improve your quality. The examinations will be complete, and you will also have accurate diagnosis. So tele-ultrasound has been in the research kind of world since the 1990s. And so I want to just take you through what has been done in the past and what is being done now. So let's just say this is somebody in 1995 doing ultrasound. The machine is huge, and they want to somehow communicate with this doctor at an offsite area. How are they going to do that? First of all, the images back then have to be stored in some kind of storage media, like a disk drive or a USB, and this is external from the ultrasound. And then you also have to have internet, of course, to be able to send the images. And then how is the expert going to communicate back with the individual who is doing the scan? Well, that has to be done through some kind of video conferencing or communication software. So it can be through email, or it can be through Skype or some other software that is a third party affiliate. But this was what was done in the past. What about what is being done now? So now we have these portable ultrasound devices. At the top here is the Philips Lumify. Down here is the Butterfly IQ, and here is the GE Venue. And with this portable ultrasound devices, their storage and communication software is integrated into the device. Therefore, they're able to communicate wirelessly to the expert, and the expert is also able to communicate through the same route. So again, the difference between the old and the new is that now the devices are smaller, and there's now a two-way communication tool that is integrated into the device. And this is the present and the future. So having said that, what are the important components of a tele-ultrasound system? Let's just say you wanted to develop one at your own shop. Well, it's important that you have a two-way audio communication or video communication tool. Having a camera is useful because then the expert is able to see the hand movement and the position of the learner and give them real-time feedback. You need some kind of storage software or archive. It's important to have internet because without this, then you cannot do this. And then also there has to be some kind of computer or laptop at the receiving dock. So now that we've had that overview of tele-ultrasound, let's talk about tele-ultrasound research. So tele-ultrasound research can be grouped into three main categories. The first one is feasibility. The feasibility studies are asking about who, what, and where. Basically, who can do this? Can it be nurses or PAs or paramedics or non-clinicians? And then what? Like, what do you need to actually do this? So you need internet, you need a computer, you need some kind of communication software. Which ones are better and which ones are worse? Then for that, and then for the where, where can this be performed? Can this be performed in austere environments? Can it be performed in space? Can it be performed only in resource limited settings? What about academic institutions? So that's the feasibility. Diagnostic accuracy, we are saying, how accurate is this compared to the standard? And the standard here is doing ultrasound at the bedside. When we talk about clinical utility, we are really asking, what is the clinical significance? How does it change patient care? What is the cost effectiveness? Now, if you look at PubMed and you type in tele-ultrasound, you will see 53 articles. 31 of them are based on the feasibility studies. 5 of them are based on diagnostic accuracy studies, and 8 of them are clinical utility studies and case reports. So let's just take a dive into the research. So speaking about feasibility, so again, it's who, what, and where. Well, I'm here to show you that this can be done in paramedics, and this was done in paramedics who were learning the FAST exam. It can be done in nurses. It can be done in the emergency department, even when you actually use low-cost tools. It can be done and taught in non-physician learners just using FaceTime. And also, interestingly, it can be done in space. So the who there, let's just say there's a checkbox. This is feasible. Now, this was a study that was done in an ED in Denmark. Again, they were just trying to see what tools do you need. So this is just a sample of what a feasibility study would have looked like. So here they're trying to compare the quality of images that you get when you use different internet servers, when you use different computers, and here when you use different communication software. They were also able to perform a qualitative analysis where they were able to identify areas of improvement. What about diagnostic accuracy? So we see that with tele-ultrasound, residents are able to accurately diagnose acute appendicitis in the ED. Pediatricians who use tele-ultrasound are able to diagnose other pediatric pathologies like intussusception, hypertrophic pyloric stenosis, MSK pathologies, and even acute abdomen. Ultrasound, the images from FaceTime are non-inferior to images that are gotten from the ultrasound machine. And also, they tested the quality of the images, over different bandwidths, and they saw which ones had good diagnostic accuracy. So again, the diagnostic accuracy is good, and the studies have shown this. And then this was the first study that I had discussed, where they had mentored residents, and they were just comparing their accuracy to the gold standard, which is an on-site expert performed ultrasound. And when you look at the test characteristics, they are very similar: the sensitivity, the specificity, the positive predictive value, and the negative predictive value. What about the clinical utility? So again, we are asking, does it lead to change in patient's care, or is it cost effective? So this was a study that was done in Canada. It was between a tertiary care center and then a center that was like a ski community. And with tele-ultrasound, they were able to identify 5 cases of intraperitoneal free fluid and 2 cases of pneumothoraces that were transferred from the ski community to have surgical intervention. This was a study that was done in Nicaragua, in a small village, Las Salinas. It's about 7 hours away from the nearest hospital. And they were able to, with tele-ultrasound, they were able to have to make new diagnosis, and they were also able to change clinical management. Well, this was an interesting case report by actually Dr. Shakui that is on this call, but using a tele-ultrasound on a cruise ship, they were able to actually diagnose an ectopic pregnancy who was, of course, evacuated. And tele-ultrasound can be used in the ICU. So again, it has feasibility, there's diagnostic accuracy, and there is clinical utility. So this was the study from Las Salinas. This was the study that was done in Nicaragua. And we see that they were able to have new diagnosis in 66% of their cases and change in management in 61% of their cases. And this was all because of the presence of tele-ultrasound. So what are the challenges? Because with any new technology or any new intervention or implementation, there will be those. So the first one, I think, is QA. So the experts have to make sure that they are examining the images of the learners to make sure that they are following the protocol, and to make sure that their images have diagnostic value. Starting costs. I think even though the handheld ultrasounds are cheaper, for many communities, they are still not cheap. So that is something that we need to be discussed, including maintenance, including buying the storage archive or the communication software. So these are things that, especially in resource-restrained communities, this is a huge consideration. Another thing is protecting patients' information. We want to make sure that with this, and I know that a lot of the portable ultrasounds that have been discussed have this integrated into their system, but again, making sure that the patient's information is protected. In communities where electricity is not constant, tele-ultrasound is going to be a huge challenge, because you need this to have that two-way communication. And last but not least, I think, there's always this kind of hesitancy sometimes where, there's this thought that, is this going to replace the local services? But tele-ultrasound is not meant to be substitutive. It's meant to support the services that are already there. So future considerations, we have to continue to emphasize POCUS educations for medical professionals. Even though there's been a lot of feasibility studies out there, there's still not a minimum requirement for frame rates, bandwidth, or image quality. And I think it's important to set those standards from our society. And then whatever protocols that are going to be developed has to be tailored to the communities in which it is going to be used. So a protocol that is, let's say, brought up here at MGH might not be the same one that can be used in Kumasi, Ghana, and that is something that has to be put into consideration. So in summary, there is a problem. There's not enough diagnostic imaging to meet the demand globally. And ultrasound is portable, it's safe, it's dynamic and is inexpensive. A tele-ultrasound is feasible, it has diagnostic accuracy, and there is clinical utility. And I think it takes off the problem of that, the user dependency that we saw in that first slide with the ultrasound and other diagnostic modalities. We discussed the challenges with QA, the starting cost, patient confidentiality, maintenance, and internet access. And I think, the next step is to continue to do research to show that there is clinical utility, that this is cost effective, and most importantly, to show that it is sustainable. I would like to thank you all for your attention this evening. This is a QR code for my references. A special thank you to SAEM for the opportunity to present, to SAUS, my organization, and the Academy of Emergency Ultrasound, GEMA, and for CURE, the Center for Ultrasound Research and Education at MGH, for all their support. Thank you, and I will take questions. Any questions?
Excellent talk, Oni. And just Dr. Eki, I just want to ask a question: is that what do you think is the urgency to actually just start this practice even tomorrow, or is that already late for a lot of these practices that we do?
I think, there has to be some kind of set protocols. I feel like there's been a lot of studies in different environments, and I think there has to be a protocol where somebody can go to some paper or statement from SAEM and say, this is how to start a program. This is the minimum bandwidth. This is the frame rate. These are the tools that you actually need. Right now, it's kind of everything is scattered everywhere. And I think there just needs to be some kind of organization to collate the amazing research that has already been done. So I think that is probably the first thing. And I think the next thing is to begin, especially now with COVID or with the restrictions that we have now, is to see how we can begin to incorporate this in the shops that we are at, just to see, number one, does this actually, make any difference to patient care? Is there any cost effectiveness? I think that is data that, number one, will help, because as you saw, there's a lot of studies on feasibility, but there's not a lot of studies on the clinical utility. And I think that is for sure lacking.
So I might have another question for you also. Then we have Dr. Fox in here right now. And I want you to ask, Dr. Fox is the chair. Dr. Fox is the dean. Dr. Fox is the educator and is the best person that we can reach out for tele-ultrasound. If you ask him, say, he has money, he has resources, you are the one that actually expressing we need this. If you want to ask him what to do, what do you ask him to do? Do you want to ask him to teach people on this? Do you want to ask him to give me like 100 ultrasound machine? What is the need? What he needs to know to actually start moving for this?
Well, I know what to ask him specifically. I would ask him, can you give me 1,000 ultrasound machines, specifically butterfly, because that is what you have, and let's go use those in number one in our ED and also in the communities that we have a partnership with. Like, we just organized a virtual ultrasound course, and we had like 200 participants from all over the world. And they were all eager and hungry for us to just, do some kind of virtual, like some kind of experience. And when I had mentioned the butterfly, everybody was so eager. Like, can you give us one? Can you teach us how to use this? So I think that if I was to ask you for anything, I would say, please give me some butterfly so I can give it to our partners in Ghana so we can start this tele-ultrasound program?
Yeah, it's interesting you bring this up. So a couple things. One is that my students every summer between their first and second year of medical school have been going to other countries and teaching ultrasound to about 10 or 15 different countries in the last 10 years or so. And, you know, the place that they go back to every year is this place in Tanzania, and at the University of Mwanza and University of Bugando. And so they're really excited because when they go there, they're teaching, and then they're teaching on this old antiquated equipment. And now it's like, you know, you get the right donors in place, and a $2,000 space is really comfortable for most donors to play in. And so now you can imagine, like, all of this global is going to really start to come online, I think, a lot better now. It's going to really democratize this and get this out to everybody. And yeah, it doesn't. And then when you leverage the tele-ultrasound part of it, it really kind of really helps stay connected to the group that you're teaching, that you have this relationship with once you leave. And so I think that's really, really cool. Is the second thing I wanted to say, and that starting this week, we have our first. So we've given out butterfly ultrasounds to all of the medical students for 2 years worth of classes. So we started 2 years ago. And so those first year medical students went through first year, went through second year. And so now we have 2 full classes, a first year and a second year class, that have been trained with and they have their own butterflies. And so now those second years are about to be third years, like this week. And so we're releasing these sort of over-engineered ultrasound medical students on all of the third year clerkships and wards with their butterflies. And we are trying to, sorry, one second. We are trying to, we created a whole longitudinal curriculum in that third year, and we're leveraging a lot of the tele-ultrasound into that. And so you can imagine there's a student who's in some clinic somewhere in their third year, or maybe they're on OBGYN, or maybe they're on surgery or post-op rounding, or whatever the issue is, and they run it and they find some pathology and they start getting excited about it, and there's no one around to talk to them about it, and they want someone to confirm this, or maybe the person that's supervising them that they're reporting to has no idea what the student's looking at, and the student is pointing something out. That's where this tele-ultrasound thing, I think, is going to be really interesting and come into play. So I don't know if I answered your question about giving you 1,000 ultrasounds. I think that I had to go out and find my own donor to do that, and to support, because I didn't, you know, these were donors. That's who created this. That's
amazing.
That's how we're able to fund all these probes. And so, you know, and it's like really important to try to keep engaging with these donors and get them excited about what we're doing here. And I've never met you, but I can tell just by talking to you and watching you that you're the perfect person to engage with donors. And so, that's really, it's that sort of having them get your, you know, selling them on your passion, but also that you can execute and be organized. It's like a combination of all of that donors really respond to. So anyways, I just wanted to point that out. I have to leave. I'm getting something I'm getting pulled into, but that was the best part of my day. Thank you for that presentation. And
thank you.
Hopefully I'll meet you in person someday.
Yeah, of course. Thank you.
See you guys. See you, Hamid.